mainly evidence-based guidelines for the induction of labor from Krishnagiri Society. And we are going to speak on methods of induction and induction of labor and second trimester induction and labor induction at term. Initially, we will start with indications and methods of induction by Dr. Shivapriya, MSOG. Dr. Shivapriya is an assistant professor at Government Dharmapuri Medical College who has completed MBBS at Kilpak Medical College and MSOG at Madras Medical College. She has presented a paper at AACOG conference in 2015, an interesting case on placenta perpetua, which was conservatively managed. And she has into her list so many journal and paper presentations. I hand over the thing to Dr. Shivapriya. Dr. Shivapriya.
Yes, ma'am.
Hello. Okay.
Good evening, ma'am. I'm Dr. Shanugapriya. On behalf of Dharmapuri OG Society, we welcome you all to the CME. Thank you, ma'am. I hand over this to Dr. Shivapriya. Good evening, ma'am. Please, sir, share the screen.
Chitra.
எப்படி பண்ண போறீங்க அப்போ?
Chitra.
Shivapriya madam, just to be on a line, madam. There is some.
Okay, sir. Okay, sir.
Screen sharing is not happening, is it? Chitrakala, what is happening?
Madam, now you can start sharing, madam. Shivapriya, madam.
Shivapriya?
Yes, sir. Yes, sir. Yes,
you
ma'am.
can try sharing screen, madam.
Okay, sir. Thank you. Is my screen visible, sir?
No, not yet.
Not yet.
No, it is not visible.
Ma'am, screen share first click பண்ணுங்க ma'am. Yes ma'am, started.
Shall I start, madam?
Yes, yeah, we are very much waiting. Start, ma.
Yes, madam. Good evening to one and all. First of all, I thank this OG Society of Dharmapuri and Krishnagiri for giving this opportunity.
Today my topic is on induction of labor, its indications and methods. So induction of labor, it is the most frequent interventional procedure in the field of obstetrics, and it is applied to about 20 to 25% of the pregnancies. Coming to the definition, so it is defined as artificial initiation of uterine contraction prior to their spontaneous onset after the period of viability, with or without ruptured membranes, resulting in progressive effacement and dilatation of cervix, ultimately resulting in the vaginal delivery. So induction can be done only when the mother or fetus will get benefit rather than delaying the birth. And also it will only be considered when the vaginal delivery is the appropriate route of delivery. The common indications for which induction is done are pre-labor rupture of membranes, post-term pregnancy, gestational hypertension, abruption, oligohydramnios, and fetal growth restriction. And when maternal medical conditions like diabetes, renal disease, liver, autoimmune diseases, when they're deteriorating, an RH incompatibility, an IUD, and even for multiparity, previous cesarean and multifetal pregnancies. So there is an entity called induction on maternal request. So without any obstetric or medical condition, when the mother asks for an induction of labor, the RCOG and ACOG favors it. So RCOG says when under the compelling psychological or social reasons, we can undergo induction on maternal request. And ACOG tells that when there is an underground of fetal maturity is attained and the gestational age criteria is fully achieved, then we can go ahead with induction on maternal request. But NICE guidelines and FOXI, it is not favoring induction on maternal request. And about the contraindications, so what are all the contraindications for vaginal deliveries itself, the contraindication for induction also. So like vasa previa or complete placenta previa, transverse fetal lie, umbilical cord prolapse, previous classical cesarean, and more than one previous cesarean, lower segment, and previous myomectomy when entering the endometrial cavity, and when there is an active genital herpes infection and gross CPD, and fetal conditions like severely compromised fetus, appreciable macrosomia, and severe hydrocephalus babies. So coming to the prerequisites, so before going into induction of labor, the women should be informed of all the risks, all the pros and cons. So what are all the complications can occur and how to manage, everything should be informed, and she should make her informed choice based on evidence-based information. And it should be undertaken only after an informed written consent. And it should be done in a health facility where we can able to manage the complications if anything arises, or facilities for cesarean section 2 with good maternal and fetal monitoring. And before going to induction of labor, we have to do a reliable estimation of gestational age, presentation, and fetal weight with an ultrasound. And the baseline fetal heart rate pattern should be obtained before going into induction. And we need to do a maternal pelvis assessment and clinical evaluation of the mother to rule out the contraindications. And the most important thing is the assessment of cervical status. So this is done to predict the likelihood of success of induction of labor. It is usually done using modified Bishop scoring system. So this is the modified Bishop score. So the original Bishop score used the effacement as one of the criteria, which is the digital assessment of the cervical length. So now it has been replaced with transvaginal ultrasound measured cervical length as modified by Calder. So the 5 criteria under modified are that dilatation, cervical dilatation in centimeter, and transvaginally measured cervical length in centimeter, and consistency and position of the cervix, and station of the head. So based on the findings, we score them as 0, 1, 2, 3. And another modification is that to the final score, we have to add 1 point when there is a preeclampsia and for each prior vaginal delivery. And we need to subtract 1 point for post-dated PPROM and for nulliparity. And when the final score exceeds 6, it is considered to be favorable for induction. So this study was published in 2006 May. So by Elgori et al. So they studied to the new modified Bishop score. So the aim of this study was to explore the pre-induction cervical length assessment as a possibility of predicting the Bishop score, predicting the success of the labor. And they included 104 women So they were modified with the cervical length by ultrasound, by especially the transvaginal ultrasound, by replacing the digital assessment. And the study showed that the original Bishop score had a sensitivity of 23% of predicting the vaginal delivery, while the modified Bishop score had sensitivity of around 62%. So the sensitivity of the Bishop score in predicting the rate of vaginal delivery has improved significantly following the modification. So they concluded that the modified Bishop score is better in predicting the success of induction and also the predicting the induction to delivery interval also. And a note on cervical ripening. So this is referred to the softening of the cervix that is occurring at the onset of labor. So this is due to the biochemical processes involved, ultimately resulting in the rearrangement of the collagen molecules by means of increase in hyaluronic acid content, and there is a decrease in dermatin and chondroitin sulfate. So ultimately, the collagen fiber strength is decreased and resulting in softening of the cervix. So this picture showed that. So the collagen fibrils are tightly packed before cervical ripening, and during it, in the cross section, we can easily see that the collagen fibrils are very loosely packed, and it loses its strength and becomes softened. So coming to the methods of induction of labor, so we have medical methods, surgical, mechanical, and others. Under medical methods, the most commonly used is that prostaglandins and oxytocin, and the other newcoming drugs which are suggested to be the method of inducing are mifepristone, nitric oxide donors, and relaxin. And under surgical, we have amniotomy, and under mechanical methods, we have sweeping of membrane, balloon catheters, and osmotic dilators. And under other methods, we have breast or nipple stimulation, sexual intercourse, and acupuncture or acupressure. So we will see one by one. So coming to the medical methods, first we have the prostaglandins. So they are useful in both cervical ripening as well as in the induction. So we have two formulations, PGE2 dinoprostone and PGE1, which is misoprostol. So dinoprostone, the available forms we have are tablets, gels, and controlled release inserts. And the route will be intravaginal or intracervical. And misoprostol, the available form is the tablet, and we have vaginal and oral route. So the basic mechanism behind the prostaglandins involved in cervical ripening is that it activates the fibroblast and promotes the release of relaxin and collagenase enzyme, and that also act on the collagen, leading to collagen breakdown with rearrangement of the molecules, resulting in cervical ripening. So another mechanism is that it acts on the vasculatures and it promotes leukocyte infiltration along with increased vascular permeability. So because of tissue hydration, there is a dearrangement of proteoglycans also, leading to collagen breakdown. So this is the dose schedule for the prostaglandin formulations. So for the tablet, it is kept intravaginal, and the dose is 3 milligram, and it is to be repeated every 6 hourly, and the maximum dose will be 6 milligrams. So 2 tablets are allowed. And for gel formulation, we have intravaginal and intracervical dose. For intravaginal gel formulation, we have to give 2 milligram for unfavorable primary cervix, and for others, dose is 1 milligram, and to be repeated every 6 hourly. And the maximum dose will be for unfavorable cervix, it is 4 milligram, and for others 3 milligram. And about intracervical preparation, the dose is 0.5 milligram, and to be repeated every 6 hourly, and the maximum dose is 1.5 milligram. That is 3 doses can be kept in 24 hours. And another formulation is that we have the controlled release inserts. It is to be kept intravaginally. It has 10 milligram, should be kept in for 24 hours. They release about 0.3 milligram per hour, and only one insert is the maximum dosage. And about the tablet, meso tablet, we have intravaginal and oral route. So for intravaginal, the dose is 25 microgram every 3 to 6 hourly, and for oral, it is every 2 hourly, and the maximum dose is 200 microgram. So this is the PG insert. So this pad contains the dinoprostone, and it will be kept in the posterior fornix at transversely with the withdrawal tape coming outside. Stimulation, we can immediately withdraw the insert. So there is a major advantage in this. And about where to use the prostaglandins. So RCOG says it is to be used in preference when there is intact membranes, regardless of parity and regardless of cervix favorability. And in case of ruptured membranes, we can choose between either prostaglandins or oxytocin. Both are equally effective. And a study compared the prostaglandins with placebo or oxytocin alone. So it showed that the vaginal prostaglandins, they increase the likelihood of delivery within 24 hours, but they do not reduce the rate of cesarean. And the main problem with the prostaglandins is that they increase the risk of uterine tachysystole with or without FHR changes. And also the prostaglandins are contraindicated in women with scarred uterus because of hyperstimulation. So they can go for uterine rupture. So prostaglandins is contraindicated in scarred uterus, and also it is to be used in caution in compromised heart diseases and glaucoma, and also in bronchial asthma. And about the route preference, RCOG says that comparing the intravaginal and intracervical preparations, intravaginal to be preferred because it is less invasive. But effectiveness is equal for both, owing to the invasiveness, intravaginal preparations to be preferred. And comparing the tablets and gel forms, RCOG prefers vaginal tablet over gel. And about the fetal monitoring, when prostaglandins are used, we need to monitor the fetal well-being with the CTG once the contractions are detected. And for uncomplicated cases, we need to go with continuous electronic monitoring at first. And when normality is confirmed, then we can switch over to intermittent monitoring. But in complicated cases, we need to go for continuous electronic monitoring. So next prostaglandin is the misoprostol. So it is a synthetic PGE1 analog. And the use of misoprostol is a big question mark regarding the induction of labor. So FOXI guidelines 2018 says that it is not yet approved for use of induction in India, but it supports off-label use, only off-label use. And the NICE guidelines says that it should be only be used for intrauterine fetal death or in relation to clinical trials. And RCOG also says the same. So since the safety aspects has not been fully evaluated, it should be restricted only to randomized control trials. And though the ACOG has approved a label for induction of for the use of misoprostol in induction 2002, they also says that this labeling does not contain the claims regarding the efficacy and safety. So the main thing obstructing the use of misoprostol in induction is that it's lower safety profile. Though it is not been approved, RCOG in the studies they have showed that it is more effective than the vaginal other prostaglandins and oxytocin in case of ruptured membranes. And when comparing the vaginal misoprostol with dinoproston or oxytocin, it is found that the misoprostol, there is an increased rate of successful vaginal delivery in 24 hours, and also the cesarean section rates has been reduced. But the main thing is that there is increased risk of uterine hypercontractility with or without FHR changes. And this is the guidance note released in 2015 by the Government of India Maternal Health Division. So they say that the oral and low dose vaginal is recommended for induction only with indications. So the recommended oral dose is 25 microgram 2 hourly. For vaginal, it is 6 hourly. And when there is no response with 2 doses of 25, we can increase the dose to 50 microgram at a 6 hourly interval. And at a time, we should not use more than 50 microgram. So the maximum dose we can go is that 4 doses up to 200 microgram is the maximum dosage limit. In comparing oral and vaginal, RCOG says that the oral misoprostol is less effective in achieving the vaginal birth within 24 hours. And also there is incidence of meconium stain liquor in oral group. So vaginal to be preferred. But the cesarean section rate and hypercontractility rates are all equal with oral as well as vaginal. But because of fail to achieve vaginal birth, oral is less preferred. Coming to the other method of medical method is that oxytocin. It can be used for both induction as well as in augmentation. So it can be used alone or in combination with amniotomy or followed by cervical ripening with prostaglandins. So when it is used followed by vaginal prostaglandins, it should be used only after 6 hours. And we have the 2 dose regimens, low dose and high dose. So the recommended regimen is that starting with the low dose of 1 to 2 milliunit per minute. at increased at interval of 30 minutes. So the licensed maximum dose is 20, and we can go up to 32 milliunits per minute. So to avoid confusion, they have given a standardized dilution and dose regimens. So it is when you mix 30 international units of oxytocin in 500 ml of normal saline, and at a rate of 1 ml per hour, it will deliver 1 milliunit per minute. And when you mix 10 international units, it 3 ml per hour will deliver. And if 5 international units is used, 6 ml per hour to be set in, and it will deliver 1 milliunit per minute. And oxytocin for induction should only be used in the infusion pumps. And if regular contraction is not established after a total of 5 international units, then the induction symptom can be stopped. And about the fetal monitoring, so continuous electronic fetal monitoring should be used when we use the oxytocin. And when there is a pathological CTG secondary to oxytocin, we can stop or decrease the drop rate of oxytocin infusion. But even after stopping the oxytocin, there is hypercontractility with abnormal FHR patterns, then tocolysis can be considered, which is subcutaneous terbutaline 0.25 milligrams. And as we already saw, for intact membranes, prostaglandins will be preferred than oxytocin. But when we choose oxytocin for induction of labor with unfavorable cervix, it should be used in combination with amniotomy. And regarding high dose regimen, it is about 4 to 6 milliunit per minute with dose increments every half an hourly. And the problem with high dose regimens is that there is increased risk of precipitate labor and higher rate of tachysystole. And even with low dose, when the incremental increase, when we increase it less frequently than 30 minutes, then there is a risk of hypercontractility. And the other newer methods of medical induction is that mifepristone. So it is a progesterone antagonist. So as the progesterone keeps the uterus quiescent, this antagonist has the opposite action. So it increases the uterine contractility, and also the sensitivity of the uterus is increased to the action of prostaglandins. But regarding the trials, there is insufficient information available from the large clinical trials to support the induction of labor. NICE guideline says that mifepristone should only be used for intrauterine death. And the 2 Indian studies which showed that the mifepristone is very promising in cervical ripening is that one by the Rutuja Atwale et al. So they have showed that the mifepristone is very safe and efficient and economical method for induction of labor at term pregnancy. So in that study, they have shown that there is an increase in chance of vaginal delivery within 24 to 48 hours. And also the LSES rate has been decreased with the use of mifepristone. And the other study is that Acharya et al. So they did studies over previous cesarean mothers, and in that also they found to be a favorable one, and it is a suitable when it is given 48 hours before the labor induction, and it is a wonder drug to be used in previously scarred uterus. And about the nitric oxide donors like isosorbide, mononitrate, dinitrate. So Cochrane database review tells us that though it is a useful tool in cervix favorability, additional data are required from large trials to over to the induction of labor. And relaxin. So this is another medical method, and the Cochrane database review tells it that the place of relaxin in induction is unclear, and further large trials are needed still more to tell it to be a very good agent for induction. Next is the mechanical methods. So we have sweeping of membranes. So it improves the rate of the mother entering into the spontaneous labor with sweeping, and it is suitable for non-urgent indications, and even it can be done simultaneously at the time of assessing the cervix after getting consent. And even if the labor doesn't start, it can be repeated. So they say when we do sweeping of membranes for 8 women, so 1 woman will not need the formal induction methods to get into labor. There's a picture showing the sweeping of membranes, and the mechanism behind is that it increases the phospholipase A2 activity and prostaglandin F2 alpha levels, and thereby increase in the intrauterine activity levels. And they say prior to the formal induction, all women should be offered a sweeping of membrane at once, and they reduce the need of the formal methods of induction. So the main disadvantage in sweeping is that the patient may have an discomfort and irregular uterine contractions and vaginal bleeding can occur, and accidentally there is a risk of pre-labor rupture of membranes. The next mechanical method, which is very commonly used, is the balloon catheters, and we have Foley induction and double balloon catheters. So Foley induction is single balloon, and it can be kept trans-cervically. So it is a very safe, cheap, and easy to store, and small degree of traction is applied, and it will be left in place until it falls out or for 24 hours. For high-risk mothers, we prefer 12 hours. And the FOXI guideline says that the Foley catheter followed by oxytocin infusion is a very good alternative method for induction than the prostaglandins. And in patients with unfavorable cervix, the Foley catheter placement has reduced the duration of labor. And also Foley catheters can be preferred in scarred uterus and with unfavorable cervix unless there are no signs of infection, because it causes less uterine hyperstimulation than prostaglandins. So that is the very important factor to consider Foley catheters for unfavorable cervix for induction. But it is contraindicated in placenta previa and with ruptured membranes and undiagnosed vaginal bleeding. So double balloon catheters, that is also accepted method, widely accepted. We have two catheters, a TUT catheter and Cook catheter. So they apply, they have two balloons and they apply pressure on both the sides of the cervix. And thereby we need not give a traction as in Foley catheters. So this picture shows the Cook catheter with two balloons. And the two balloons, one on the uterine side and one on the vaginal side. So the patient may experience minimized discomfort when compared with single catheters. And this picture showed that the two balloons, one on the uterine side of the cervix and another on the vaginal side. So there's a TUT catheter. So it is also showing a promising evidence in induction of labor with previous cesarean deliveries with unfavorable cervix. And this meta-analysis compared the double versus single balloon catheters by Zhuoyu et al. So they showed that both the catheters, they perform similarly, but single balloon device will be preferred to be more economical and also practical. And this Cochrane database review in 2019, they showed that the mechanical induction is as effective as vaginal prostaglandins, but the mechanical methods, they have a more favorable safety profile because of the less uterine hyperstimulation. And going to the hygroscopic dilators, so this have the mechanism is that they absorb the fluid from the surrounding tissue and thereby they swell and dilate the cervix and induce labor. So we have natural as well as synthetic. So natural is the laminaria tent. It is from the seaweeds laminaria japonica, and the synthetic dilators it is called as dilepin S, and that is composed of polyacrylonitrile. So this picture shows that the laminaria tent natural with the guide wire, and this is the dilepin S, which is the synthetic osmotic dilators with the guide wires for easy removal. And this picture showed that, so this is the one which is used before inserting. So usually at a time we insert 3 to 4 synthetic dilators into the cervix, and after it swells, it appears like this. So this is a natural picture, and here we have a protocol that when the osmotic dilators are used, we wait for 12 hours, and when there is a favorable Bishop score, we go ahead with oxytocin with amniotomy, and less favorability, we can repeat up to 3 times. So even then it is not achieved, then it is considered to be a failure and go for a cesarean section. And the evidence, though there is a lower risk of uterine hyperstimulation with laminaria, but regarding the use in induction and reduction of cesarean, it is not certain. Evidence is not fully available. And this is a Delafold trial. It showed that it compared synthetic osmotic dilator dilepin S with Foley balloon. So it showed that both are equally effective, and dilepin S is not inferior for cervical ripening. So advantages of dilepin S over Foley is that they have a safe profile when there is no protrusion from the introitus. So in Foley catheters, there is a protrusion from introitus, and the mothers may feel uncomfortable. So that is avoided in case of dilepin S, and there is no need to keep under tension and better patient satisfaction. Coming to the surgical methods, we have amniotomy. So it involves rupturing the membranes overlaying the cervix. The forewater is drained, and thereby there is a uterine decompression and local prostaglandin release. With the prostaglandin release, there is a stimulation of uterine activity. So it can be used for induction as well as in augmentation of labor. So in induction, it is considered to be an early ARM. So there is less than 4 centimeter of dilatation. And fetal heart rate should be assessed before and immediately after amniotomy. And also the question of amniotomy alone, again, it is questionable like that of misoprostol. So Foxy guideline says that amniotomy alone as a primary method of induction is not recommended by Foxy. So they say oxytocin should be commenced either immediately or after 2 hours, depending on the intensity of uterine contractions. And also ACOG says that it can be used when the cervix is favorable, but only amniotomy for induction, there is insufficient evidence. And NICE guideline says that even amniotomy alone or along with oxytocin, it is not to be used as a primary method. So this another study compared amniotomy alone and amniotomy followed by oxytocin. So the combined method have a shorter induction to delivery interval than the amniotomy alone. And we have to note that amniotomy is contraindicated in HIV mothers and active genital herpes infection. So because of the risk of vertical transmission. So coming to the methods, we can use amnicot. So it is a single-use finger cord with a plastic hook attached at the fingertip, and it is a single use. And by means of amni hook also, we can do an amniotomy. So this is available in plastic as well as in wooden with a hook attached for induction of rupturing the membranes. So this picture shows the amni hook, and even for coccus, forceps, and artery forceps can be used for induction for amniotomy. And in amniotomy, we have certain risks like infection and abruption. Sudden release of the fluid may result in abruption, and cord prolapse and pulmonary embolism can occur. Coming to the other methods, so we have breast stimulation or nipple stimulation. So it has been suggested as a method of induction, but studies have shown that there is a reduction in women not entering into labor after 72 hours. So, and also a reduction in the PPH. But until the safety issues have not been evaluated fully, so it should not be considered for high-risk population. And Cochrane review says that further trials are needed to evaluate its safety profile. And about sexual intercourse, the role in induction is uncertain. So Josephine et al. Says that it may be due to physical stimulation of the lower uterine segment or endogenous release of oxytocin as a result of orgasm or from the direct action of the prostaglandins from semen. And about the randomized control trials meta-analysis, they showed that the place of sexual intercourse in induction, it is not proven and it does not significantly increase the onset. And about acupuncture and acupressure, again the studies are limited, and the evidence to prove it to be an induction of labor is very limited. Cochrane review says that acupuncture, though they show an improvement in the cervix favorability, but in reducing cesarean section rate and entering into labor, there is no clear benefit. So to conclude, in a nutshell, when we have an unfavorable cervix, generally we use the methods based on the cervix favorability, parity, and the membranes whether intact or not. So for unfavorable cervix, mechanical methods or vaginal prostaglandins can be used. So because of the better safety profile, mechanical methods can be taken for unfavorable cervix. And when the cervix is favorable, we can go ahead with low dose oxytocin with amniotomy. And for intact membranes, generally prostaglandins are preferred. But if you use oxytocin, it should be used in combination with amniotomy. And for ruptured membranes, either prostaglandins or oxytocin. And for about amniotomy alone and for misoprostol regarding safety issues, it's a question mark to be used for induction. And COG says before to formal induction, all women should be offered a stripping of membranes. And there is insufficient evidence and need for large trials to work on like mifepristone, nitric oxide donors, relaxin, and breast stimulation, acupuncture, and sexual intercourse. Thank you.
Thank you, Sivapriya. That was a very, very interesting topic, and you have done very full justice to that. And I just wanted to highlight on one thing, the advantage offered over this induction of labor by these methods. It will allow ambulation. When you put them on oxytocin with CTG monitoring, the patient is feeling really like a patient.
Yes,
they lose their morale and with every pain they start behaving very funnily. Whereas if you just apply this gel or misoprostol tablet also, for that matter, we do use. So the patient is made ambulant and they are given the normal, diet and other things. They are allowed to be with their relatives and all. So that it offers a very great advantage, I think, over oxytocin. Of course, oxytocin is always combined with amniotomy, as you said. And you have pointed out all the relevant features for these inductions, do's and don'ts. Thank you so much. It was a very interesting topic and you've done full justice to the topic.
Thank you, ma'am.
Thanks once again, ma. So Sushma, can we move on to the next topic?
Yes, madam. Yes, ma'am.
Yeah.
Now I would like to introduce Dr. Kanimuli. I think next talk is on second trimester induction.
Yes, madam.
Second trimester induction is by
Kanimuli,
Dr. Kanimuli.
Yes, madam.
Okay. Now, I would like to introduce Dr. Kanimuli, who would be speaking on second trimester induction, who has finished her UG and PG both from Madras Medical College, who is at present the assistant surgeon at Harur Simong Center, and who has done a paper presentation on methotrexate in heterotopic pregnancy. Now over to you, Dr. Kanimuli, for the presentation. Dr. Kanimuli, are you?
Madam,
there?
1 minute, madam. 1 minute. Just a minute.
Shiva, you're all in the same room, isn't it?
Yes, madam. Yes, madam.
Okay, what is the problem? What is happening? Why Shanmuga Priya was not introduced? And
Good evening, ma'am. This is Dr. K. Kanimuli.
yeah.
We're going to discuss about labor induction in second trimester. Shall I start, ma'am?
Yes, ma. Yes. You can go ahead.
There is nothing new to say in the second trimester abortion, but what
Ma'am,
we discuss.
sorry to interrupt, ma'am. Your screen is like your PPT is not seen, ma'am.
Okay.
Please stop share and share again, ma'am.
Madam, is it seen, madam?
Yes, ma'am. Yes, ma'am.
Good evening. I am Dr. J. Kanimuli. I am going to discuss about labor induction in second trimester. There is nothing new to say. Okay. But what I'm going to discuss here is what we are practicing in the current scenario and what are the queries running in my mind when I'm handling a second trimester abortion. Indication for second trimester abortion is entirely different from term gestation. In case of third trimester, it is entirely a medical reason. But in case of second trimester, it is both medical and social reason. There is one terminology called social induction of labor. Absence of definite medical indication. Some medical indications are severe preeclampsia, preterm premature rupture of membrane, failure of pregnancy, intrauterine death. So far, there is no contraindication for induction of labor during second trimester, but only contraindication if the physician mind says no. Physician has a legal rights to say no in case of second trimester abortion. Keep in mind that outcome is never a successful live birth. Handling of induction failure is not so easy as third trimester induction failure. Legal issues. So always go as per protocol. Informed written consent for every adverse outcome. Informed written consent for what we are going to do when induction fails. Some of the complications are hemorrhage, cervical laceration,
retained products of conception, infection. Some precautions that we have to keep in mind is when the pregnancy is more than 14 weeks, please rule out placenta accreta, because when we are handling a case of placenta previa or previous C-section, sometimes we may held up in retained placenta. That time we have to do curettage. Please rule out placenta previa before Foley induction. According to ACOG guidelines, second trimester defines 14th week and 0 days to 27 weeks and 6 days. Second trimester abortion carries a more risk than other trimesters. 10 to 15% of maternal death due to second trimester abortions. According to RCOG evidence-based clinical guidelines, second trimester abortion recommendation is pharmacological management seems to be an appealing method. Mifepristone, misoprostol, it is an effective regimen appropriate at any gestation. Coming to 13 to 24 weeks of gestation, 400 microgram misoprostol every 3 hours. When it is 25 to 26 weeks of gestation, 200 microgram every 4 hours. If it is 27 to 28 weeks of gestation, it is 200 every 4 hours. In case of fetal death in 13 to 26 weeks of gestation, 200 microgram every 4 to 6 hours. In case of fetal death, 27 to 28 weeks of gestation, it is 100 microgram every 4 hours. Coming to mifepristone. Mifepristone in second trimester abortion. Randomized control trial says if we are using mifepristone and not using mifepristone. If we are using mifepristone, the expulsion time interval is 10 hours. In case of not using mifepristone, it is 18 hours. Placental retention, it is 3.1% in mifepristone. It is 6.3% in no mifepristone. Hospital stay seems to be 6 days in case of mifepristone. It is 8 days in case of no mifepristone. Analgesic requirement, it is 27.2 mg in case of mifepristone. In case of no mifepristone, it is 39.3 mg. According to RCOG guidelines, there is a randomized control trial confirms that there was no difference in efficacy between 200 mg mifepristone or 600 mg mifepristone. Usually this query will runs in our mind whether we have to use 600 mg mifepristone in case of second trimester abortion. No, 200 mg mifepristone is more than enough in handling a second trimester abortion. Randomized control trial comparing the efficacy of same-day administration of mifepristone and misoprostol for termination with the standard 36 to 48 hours protocol. The research shows that group 2, 36 to 48 hours shows 92% outcome. What I'm considering here is no requirement of medical or surgical intervention beyond the initial dose of misoprostol. In case of group 1, where we are giving mifepristone on the same day, it is like 6 hours, it is 79% only outcome. So 36 to 48 hours regimen, highest success rate. Invasive or non-invasive. The trial is whether the procedure results in non-invasive or invasive procedures. Retrospective analysis of 386 women who underwent termination of pregnancy between 20 and 24 weeks of gestation. We are giving mifepristone 200 mg, followed by that misoprostol 800 mg, followed by 400 mg every 3 hours up to 4 doses. If abortion failed, repeat mifepristone 200 mg 3 hours after the last dose of misoprostol, give rest for 12 hours, then start the routine course of misoprostol. 97.9 to 99.5% delivered within 24 and 36 hours. 5% incomplete abortion with retained products. This is invasive. In case of nulliparous women, it took longer time. Conclusion, what I want to conclude is 200 mg mifepristone with vaginal misoprostol, it is safe and effective for non-invasive termination of pregnancy. Only 5% required invasive procedure, that is retained placenta. 1 or 2 day interval regimen. 1 or 2 day interval mifepristone, misoprostol interval for second trimester abortion. Retrospective study shows that if you are giving 1 day interval, it is 9.8 hours. If you are giving 2 days interval, it is 7.5 hours. Use of misoprostol dose may be high in case of a 1 day interval. 98% of expulsion within 24 hours. When the weeks are higher and it is a nulliparous woman, it took longer time. When mifepristone is not available, okay, only misoprostol alone can be used. Dosage regimens are 200 microgram hourly, 400 microgram 6th hourly, 600 microgram loading dose followed by 200 microgram 6th hourly. The best regimen is 400 microgram. Regimen is preferred. Oral regimen inferior to vaginal regimen. Dose more than 800 microgram, there is a more side effects. When misoprostol is used along with mifepristone, it is having high efficacy. When coming to the pharmacokinetics, bioavailability, vaginal route is higher. Peak time, it is very shortest with sublingual route. When we are comparing alternative methods like interamniotic hypertonic saline, interamniotic PGF2 alpha infusion, oxytocin infusion, vaginal geniprost, misoprostol is superior to all other alternative methods. Interval of use, 3 hours regimen is better than 6 hours regimen, but trials says that if you are maintaining the interval between 3 to 6 hours, it's a good choice for mid-trimester termination. Misoprostol 400 microgram every 3 to 6 hours interval by vaginal route is safe and recommended. Its conclusion. What are the factors affecting induction abortion interval? Nulliparous, it will lengthen the time. Younger maternal age, it will lengthen the time. Increasing gestational age, it will lengthen. When we are comparing the length of the cervix or any fetal anomaly will affect this induction abortion interval, there is no correlation. Coming to the prior cesarean delivery, is it associated with higher complication when compared with unscarred uterus? No. Vaginal 400 microgram every 6 hours interval in scarred uterus is same as that of unscarred uterus. Dosage should be low and should not double the dose when there is a no initial response. Subsequent pregnancy after this termination, outcome of subsequent pregnancy after misoprostol used terminations, there are the results are varying. Some studies shows that there is an ill effect. Some studies shows that some will show preterm or very preterm delivery. Safe abortion guidelines shows it's current 2018. The past one is 2012. Time period between mifepristone and misoprostol, the current guidelines is saying it's days. Older guidelines saying it's hours. Loading dose, use of loading dose of misoprostol is not necessary. This is the new guidelines. Previously, we are using a loading dose. Now it is not necessary. Maximum number of doses of misoprostol, now it is nil. In this guidelines, we do not provide a maximum number of doses of misoprostol. In previous, it is 5 doses. Coming to the Foley's catheter, please rule out infection. It is both mechanical effect and medical effect. Both are already discussed. But coming to the trials, clinical obstetrics, gynecology, and reproductive medicine says that when we are using intracervical Foley catheter and vaginal misoprostol for termination of second pregnancy, 3-year observational study, group 1, only misoprostol, group 2 is a combined group. There is a marked difference in the duration. Group 1, only misoprostol, it is 15 hours. Group 2, it's a combined group, it's 10 hours. What I want to conclude is, it's safe, accepted method for termination of a second trimester pregnancy, preferably in nulliparous women. Journal of Medical Science and Clinical Research shows that efficacy and safety of Foley's bulb with misoprostol, whether introducing a Foley bulb will cause cervical injury or not. It is done in 66 women. Conclusion, there is no major complication. There is no cervical damage. Sequential use of Foley's catheter with misoprostol and second trimester pregnancy termination in women with and without C-section. It is a prospective cohort study. Outcome shows that abortion within 24 hours, rate of surgical removal of placenta, major maternal complications are same for both the scarred and unscarred uterus. Foley's catheter create with and without tension. When you are creating a tension to the Foley's catheter, is there any difference in the expulsion interval time? No. What they are saying is maybe there is a difference in the expulsion of Foley's from insertion time is bit earlier in case of creating tension. Stretching that Foley's is creating the tension, but there is no difference in the expulsion of fetus. Using only Foley's catheter without prostaglandins, yes, after expulsion of catheter, start with 30 units of oxytocin. What they are saying is induction to expulsion of catheter, there is a 3 hours difference. Induction to delivery of fetus, there is a 5 hours difference. So prostaglandin PGF2 alpha is preferred when it is a case of a poor patient. There is no availability like that. Foley catheter only may be used. Some important facts. Quality of medicine used is an important factor that can influence the process and overall success of a medical abortion. Intrauterine devices should be removed before taking abortion-inducing drugs. If the patient has allergy to the drug, don't go for medical abortion. If infection is present, patient in shock, preferably go for surgical evacuation. Some new medical amendment bill in 2021, enhancing the upper gestational age limit from 20 to 24 weeks. Opinion for only one provider will be required up to 20 weeks. After the 2 providers, upper gestation limit not to apply in case of any substantial fetal abnormalities. Name and other particulars of a woman whose pregnancy has been terminated shall not be revealed except to a person authorized in any law. Ground of failure of contraception extended to women and their partner. This is some request form. This is to be filled by the patient. This is ours. This is to be filled by ours. This is patient. When all the measure fails, go for invasive procedure. The thing which I want to conclude is mifepristone followed by misoprostol. When nulliparous woman, go for Foley's catheter. Success rate will be high. Thank you.
Thank you so much, Kanimuri. Your talk was very crisp and clear cut, and you are very definite about what you want to express. It is very good.
Thank you.
So you made us all believe in what you are practicing. That's good. So Sushma, over to the next. What about Dr. Shanmugapriya?
Madam, I'm available here, ma'am.
Yeah.
Yes, ma'am. Next, I would like to introduce Dr. N. Shanmugapriya, who is a senior assistant professor in Dharmapuri Medical College, who has completed MBBS from Madras Medical College and MSOG from Tanjore Medical College, and who has undergone training in laparoscopy, hysteroscopy, and in advanced fertility technique, and who has published an article in International Journal of Reproduction, Contraception, Obstetrics and Gynecology on the effectiveness of liquid-based cytology in cancer cervix screening, and her field of interest is high-risk obstetrics. Over to you, Dr. Shanmugapriya, for your presentation.
Thank you, madam.
You have to share your screen, I think.
Madam.
Ma'am, may I help you, ma'am?
1 second, ma'am.
Meanwhile, Sivapriya, you are there?
Yes, madam.
No, I just wanted to ask you, you have not told about meconium stained liquor and its association with induction.
Okay, madam.
And what about the time interval after the vaginal prostaglandin? How long will you wait before starting oxytocin drip?
6 hours, madam.
6 hours.
Yes,
Okay.
madam.
And I think MSL is more common with oral.
Yes, madam.
Yeah?
Yes, madam.
Oh.
Oral misoprostol.
Okay, but what is the rationale behind it? Vaginal is supposed to be more effective, but the side effect with is just more with oral, is it?
Yes, madam.
Why? I really don't know. That is why I'm asking you. You have to find out and let me know next time when I see you.
Yes, madam. Yes, madam. Sure.
How can one be more effective
Hmm.
and with the effect and more less effective with side effect?
Yes, madam. Yes, madam.
So, unwanted effect of meconium staining is more with the oral, isn't it?
Okay, madam.
Priya, madam, we received one question from our
Question box
attendees,
is, yeah.
Yes, madam.
Ragadipti Sekhar. She wrote that MISO used practically for induction, but documentation allowed or not.
Sir?
MISO documentation.
But sir, but according to FOXI ICOG guidelines, actually it has not been approved for to be used. It supports only off-label use in India.
But 2015 Ministry of Health, you have told that it is
Yes, madam, but
approved the
FOXI
vaginal dose.
FOXI guidelines 2018 says that it has not been approved, madam.
Yes. Okay, okay. So they are also, they keep on changing their verdict.
Madam, but it is effective, but because of the safety profile.
But we will not be protected if something goes wrong, isn't
Yes,
it?
madam. Yes, madam.
That is what they are trying to say. You can use it at your own risk.
Yes, madam.
Fine. And regarding twins and induction, I think Shanmuga Priya will be talking, right?
Yes, madam.
Yes,
Yes,
ma'am.
madam.
Okay, ma. Okay, okay. Right, right.
Laptop is handbook, ma'am. Just a minute, ma'am. Is my screen visible, ma'am?
Not yet.
Ma'am,
Yes, ma'am.
visible, but it is the PPT is not seen, ma'am. Only the documents. I can see your desktop.
The first page only is there.
Stop share, madam. Okay, ma'am. Market screen.
Is it visible, ma'am?
Yes, yes, it's visible. It's visible, ma'am.
Okay, ma'am. Thank you. So good evening, one and all, and who are all present in this meeting. And it's my pleasure being presenting this topic on labor induction at term, and which is the need of the hour. And as these days the labor induction are increasing, where it is a controversial concept still, and which influences the women's birth experience. An induction of labor is still more painful compared to spontaneous onset of labor because it involves so many medical interventions, as well as the hospital stay may be increased. But still, the main thing behind induction of labor is it is directly linked to reducing the maternal mortality and morbidity, because it has a potential benefit in preventing the maternal complications or in reduction of complications and improving the pregnancy outcomes. And also it reduces the emotional burden on the mother, especially in case of special situations like IUD, oligohydramnios, and so on. And these days, as we know, these are the days of litigation where many people demand more for normal vaginal delivery, and so many complications, which is really a nightmare for the consulting obstetrician to convince either the patient or their attenders or their well-wishers. So really, we need to stick on to some of the guidelines and evidences whether to terminate or to prolong. So here we move on to the labor induction at term and evidence-based discussion. So the two question that arises when I think this topic is when to induce and how to induce. So the percentage of women remaining undelivered after 40 weeks is at 41 weeks, it is approximately 19%, and at 42 weeks, it's approximately 3.5%. So mostly they deliver before 40 weeks. And the risk of fetal death, which also increases significantly with the increasing gestational age. At 38 weeks, it is 0.25, and at 42 weeks, it is 1.5%. So every pregnancy is a risk, where it can be classified either as a low risk or a high risk, and no risk pregnancies can never be seen. So low risk pregnancies, for every pregnancies, elective induction can be planned if not went into spontaneous labor, can be planned at 40 to 41 plus 6 days. So if it is more than 41 weeks, why we need not prolong is that the risks of cesarean section and NICU admission, stillbirth, and neonatal death are more. So according to ARRIVE study, it is a randomized trial of induction versus expectant management study, where the elective induction of labor in low risk nullipera at 39 weeks, they say that it reduces the rate of cesarean delivery without significantly increasing the adverse perinatal outcomes. And this may be also be not for if not for all low risk pregnancies, can be considered to women conceived through IVF or nullipera with advanced maternal age. So next, we're coming to the high risk pregnancy. So every high risk pregnancies, the question that arises, when to induce, when to terminate, because the mother as well as their relatives, everybody will be panicked that when the baby will come and when the mother will get rid of all these things. So first, I'm going to discuss about term pre-labor rupture of membranes. So there are so many guidelines regarding. So each guideline say when the patient, when the mother enters the period of maturity, that is a baby enters the period of maturity more than 37 weeks. So delivery is the need of the thing. So according to Foxy, active management with induction is suggested. And according to ACOG practice bulletin, it is induction at the time of presentation, either with oxytocin or prostaglandins is indicated. And insufficient evidence on the use of mechanical methods in case of term PROA. And adequate time should be given for the latent phase of labor to proceed. And if active management with induction is made, then there will be reduction in chorioamnionitis, endometritis, and NICU admission and need for antibiotics in the neonates. So according to RCOG guidelines, immediate induction is needed. And if we go for expectant management, it should not exceed 96 hours following rupture. So according to NICE guidelines, the induction should be approximately 24 hours after rupture. So finally concluding, having in our head all these guidelines, in a term PROM, we can wait for 24 hours, provided all the maternal and fetal conditions are okay with favorable biophysical profile and Bishop score. We can wait for 24 hours after rupture for spontaneous onset of labor. So if the woman is GBS positive, that is group B streptococcus positive, then expect induction of labor as soon as possible. In coming to the hypertensive disorders in pregnancy, so induction should be planned at 37 weeks, which improves the maternal outcome. So there is a study known as HIPITATE study, that is hypertension and preeclampsia intervention trial at near term. So it is a randomized clinical trial, which was conducted from October to March 2005 to 8, which showed women with gestational hypertension or mild preeclampsia at term, the induction of labor compared with expectant management was associated with increased maternal outcome or improved maternal outcome without compromising the neonatal outcome. So when the fetus attains maturity after 37 weeks, having diagnosed as hypertensive disorder, no point in waiting for the further prolongation of pregnancy, which will further deteriorate the maternal outcome. Next is gestational diabetes mellitus, where the induction of labor versus expectant management in GDM is favored at 38 to 39 weeks, according to Foxy. And what are various recommendations, or when the gestational diabetes mother on well controlled with medical nutritional therapy, induction can be planned after 39 weeks. And on insulin and OHA, well-controlled GDM, the induction can be planned at 38 weeks. And if it is an uncontrolled GDM, then it should be individualized. So according to NHM guidelines, vaginal delivery should be preferred unless otherwise there is obstetric indications for cesarean section. So GDM is associated with delayed lung maturity, as we all know. So well-controlled GDM on medical nutritional therapy, we should try to postpone the delivery or induction of labor as far as possible after, and not before 39 weeks. In fetal macrosomia, you have to consider, according to NHM guidelines, they consider the primary cesarean section at 39 weeks to avoid shoulder dystocia. But this is again a contrary to a Cochrane review, where the expectant management versus labor induction for suspected fetal macrosomia, where labor induction results in increased cesarean section rate without improving any perinatal outcome in case of suspected fetal macrosomia. So we can wait for spontaneous onset of labor as per normal labor protocol, even in case of fetal macrosomia. So breech delivery, about 3 to 4% of all pregnancies, they reach term with breech presentation, with fetus in breech presentation. So the perinatal mortality is lower for planned cesarean section compared with planned vaginal breech delivery, according to the term breech trial RCOG. So what are the drawbacks of this term breech trial is actually comparing the two groups, those underwent cesarean section and vaginal birth, there are no difference between the two groups in when the maternal mortality and morbidity is concerned. At the same time, the long-term consequences of the fetus are not highlighted in this trial. So again, so for a breech delivery, we have to, it depends upon the efficiency of the consultant obstetrician and the individual decision whether to take up for normal or cesarean delivery. So intrauterine fetal death. So RCOG Green Top Guidelines 55, according to it, immediate or imminent induction of labor is indicated when the mother has sepsis, preeclampsia, abruption, or in case of patient's request. And expectant management, the risk for 48 hours is very low. So more than 48 hours, we have to monitor the mother for coagulation profile. Every twice a week, we have to monitor her. So more than 85% of women, the labor starts spontaneously in 3 weeks of diagnosis, and in 25% who retain more than 4 weeks, DIC sets in. So practically, this can't be possible in our setup where we can go in for the patient request for immediate induction of labor. So the mode of induction in case of intrauterine fetal death is the mechanical methods according to ACOG, especially the balloon catheter, or in, the prostaglandins PGE2 or E1. As already the previous speaker, Dr. Shivapriya told, PGE1 is indicated in case of intrauterine fetal death. So it can be used and recorded. And after 28 weeks, as per ACOG guidelines, the IUD labor has to be managed according to obstetric protocols. And next important thing and the interesting thing is the previous cesarean section, whether to go in for a vaginal birth, because so many mothers where cesarean section was taken for a non-indicated, non-recurrent indications in the previous pregnancy, they will again ask for a normal vaginal delivery. So what can we do? So main essential prerequisites for induction of labor is facilities for maternal fetal monitoring and facilities for emergency cesarean section. So according to Foxy, 60% of inductions result in vaginal delivery, where the main success depends upon the favorability of the cervix and the prior vaginal delivery. So there are some criteria where that should be met with before proceeding on to VBAC. That is vaginal birth after cesarean section. So the mode of induction either can be Foley balloon catheter or oxytocin with amniotomy, and no prostaglandins can be used. And only few RCTs has been performed that provide comparative choice of trial of labor after cesarean section or elective repeat cesarean delivery. They are still the choice of TOLAC or ERCD are still controversial, and lack of education about TOLAC is often associated with ERCD. So that again depends upon the efficiency and the knowledge of the consulting obstetrician whether to go in for a TOLAC or the ERCD. So the RCOG Green Top Guidelines 45, according to it, although the success of TOLAC is more than elective cesarean section, induction and augmentation, though not contraindicated, it still remains considerable disagreement among the clinicians on their use because of fear of uterine rupture. So the mechanical methods, they are the better mode of induction with lower risk of scar rupture, and prostaglandins can be used with caution according to RCOG, and oxytocin also with caution. So considering that main thing in previous cesarean section, the right is that you have to choose the right patient and the right mode of induction for successful vaginal birth after a previous cesarean section. And next is twin delivery, where nearly 70% of the twin deliver between 35 and 37 weeks, and proportion deliver before this because that relates to the chorionicity, growth restriction, or electively due to maternal request. In the remaining one, there are concerns over perinatal risk as gestation advances. So induction of labor is again not a routine in twin pregnancy, but consideration before induction of labor, again based on chorionicity, fetus presentation, estimated fetal weight, and previous uterine scar. So there are many retrospective studies which demonstrate that perinatal mortality rate is lowest for birth at 37 weeks, and stillbirth rate increases from 38 weeks. So finally, the recommendations. Consider vaginal delivery in uncomplicated pregnancy for monochorionic diamniotic at 36 to 37 weeks and dichorionic diamniotic at 37 to 38 weeks. And for monochorionic monoamniotic, after corticosteroid coverage, we can take a cesarean section at 34 weeks. And for intrauterine growth restricted babies and induction of labor, infants with fetal growth compromise, they are at higher risk of perinatal death, nearly 5 times the of association that exists between the perinatal mortality and growth restriction compared to that of normal weight infants. So the RCOG guideline development group unable to locate any studies that considered IOL in these babies. So Digitate study, it is nothing but a disproportionate intrauterine growth intervention trial at term, where it compares the expectant versus immediate birth at term, which showed no significant difference in maternal morbidity and perinatal death. So what is the recommendation? The plan of delivery, again, it is individualized, and timing depends upon the severity of intrauterine growth restriction and the presence of evidence of fetal compromise, especially the Doppler changes. And induction of labor, it is not recommended for severe IUGR. And small for growth babies in fetuses, 50 to 70%, they are constitutionally small babies with predicted normal outcome. So according to RCOG Green Top guidelines, SGA fetuses, they can be offered induction of labor at 37 to 39 weeks. And again, if we need to prolong it at 40 weeks till 40 weeks, we have to monitor them with 2 weekly umbilical artery Doppler and growth assessment. Next is oligohydramnias. When the AFI is less than 5 centimeter, induction of labor is offered at 37 to 38 weeks. And if it is more than 5, less than 8, it can be prolonged beyond 38 weeks. So meantime, the patient should be counseled and monitored by weekly AFI, Doppler, twice weekly CTG, and giving fetal kick count to the mother. And if the patient presents with reduced fetal movements, 70% of pregnancies with a single episode of reduced fetal movements, they are uncomplicated. So RCOG statement decision whether or not to consider IOL at term with reduced fetal movements is by individual preference. So consider what we say is consider IOL for, they say is for recurrent reduced fetal movements, and if a single episode of reduced fetal movements at term more than 40 weeks can also be considered for induction of labor. Obstetric cholestasis. So according to Foxy, induction should be considered between weeks 37 to 38 weeks to improve the perinatal outcome. An earlier induction around 36 weeks can be considered in case of severe biochemical abnormalities when there are deranged bile acid levels to improve the maternal outcome. And here comes the COVID-19, which is splendid now, and the induction of labor, what we are going to do. So in asymptomatic women, induction of labor with medical indications should not be postponed or rescheduled. Induction, if appropriate, at 39 weeks can be considered. So in critically ill patients, consideration should be given to delivery more than 34 weeks as delivery optimizes the maternal respiratory status. And COVID-19 alone is not an indication for cesarean section. So what are some of the criteria? Is delivery mode should be dictated by the obstetric indications. Routine induction protocol can be followed. Prolongation of first and second stage of labor can be augmented. And evidence, though lacking, delayed cord clamping should be avoided. So continuous CTG monitoring should be enhanced, and so there are increased chances of fetal distress in COVID-19, and no invasive procedure, fetal scalp pH testing or internal fetal heart rate monitoring to be done in those babies. So some of the terminologies we should know, that is what is induction of labor, as we heard already, that is artificial initiation of contraction in a pregnant woman who is not in labor to help her achieve a vaginal birth within 24 to 48 hours. So what is successful induction? So vaginal delivery within 24 to 48 hours of induction is successful. So any success, the thing is any failed induction. So when we say it as failed induction, a failure to achieve regular uterine contractions after one cycle of completion of cervical ripening consisting of insertion of 3 intracervical prostaglandin E2 gel, that is 3 grams at 6 hourly interval, and then 12 to 24 hours of oxytocin administration after rupture of membranes if feasible. Because if the cervix is not favorable, prior amniotomy should not be done. So that's what this, if feasible, amniotomy can also be done for induction. And 1 PGE2 pessary 10 milligram within 24 hours. Elective induction, induction of labor in the absence of acceptable fetal or maternal indications. And what is other thing is hyperstimulation. So when there is increased uterine contractions, okay, so with this nothing but for 5 or more uterine contractions in a period of 10 minutes, average over 30 minutes. Okay, so this associated with or without fetal compromise. If it is associated with non-reassuring fetal heart rate changes, it can be said as hyperstimulation, where if it is without any fetal heart rate changes, it is known as hypertonus. So this is RCOG checklist, where whenever a pregnant mother comes to a clinic, we should assess the gestational age, confirm the gestational age, and if she is far from her term, then we have to consider whether there is any associated complications present or not. If there are any complications present, then the protocols, as we discussed earlier, can be followed. And if with low risk pregnancy, then we can follow the other methods of, we can ask her to review at 40 weeks, where we can start our mechanical methods of induction like sweeping of membranes. And after 41 weeks, we can start a routine protocol provided the bishop's biophysical profile and other favorability, the maternal conditions are normal. And these are some of the induction methods, what we heard earlier itself from the speaker. And methods of induction of labor, medical, surgical, and mechanical, as we all heard already. The medical is prostaglandin, PGE2, and oxytocin. Surgical is amniotomy, and mechanical is membrane sweeping and balloon catheter. From misoprostol, PGE1 is not yet approved for induction of labor by the Drug Control General of India, according to Foxy. So it is off-label again. And components of induction of labor, the two things, one thing is cervical ripening, other thing is initiation of uterine contractions. So in cervical ripening, we can use either mechanical methods or hormonal methods. So this is the mechanical method, where it's a Foley balloon catheter, which is here seen just above the internal os. So what is the advantage of this mechanical ripening? Again, it is a revision, that is advantages are lowest chances of uterine tachysystole and or FHR changes, low cost, equally effective in achieving the vaginal delivery as hormonal, and safer in previous uterine scar and multipara. So disadvantages, it's prolonged induction. We have to wait for 24 hours and chances of infection are there and can't be used in pre-labor rupture of membranes. So this is a study where it is published in International Journal of Reproduction Contraception, and where it is a comparative study comparing intracervical Foley catheter and intracervical prostaglandin E2 gel for pre-induction cervical ripening. So the result of this, Foley catheter is safe and effective method for induction of labor, and the induction delivery interval is also shortened when compared to prostaglandin E2 gel. So this is a hormonal method, the cervidil and prostin, where cervidil is a vaginal insert and prostin either intracervical or vaginal, where it is nothing but the gynoprostome. So cervidil, I think the previous speaker, it's a vaginal insert, dealt with in detail. These are the methods of insertion of cervidil, where we have to, with gloved hands, we have to take the tape and insert it into the posterior fornix, encircling the posterior lip of the cervix in the posterior fornix. And then the withdrawal tape is ejecting out, where whenever we need to take it out, we can easily remove it. So what are the advantages? It's relatively easy to insert, can be inserted in patients with cervix completely closed, and can be removed quickly and easily. With longer duration of action, it minimizes the patient visits, because we are going to admit these patients, but still in foreign countries, they insert, they observe the FHR, and they discharge the patient and make them review after 1 day or so. But what we do is, any induction protocol, we admit the patient, whether mechanical or hormonal, whatever the method we choose. So it should be removed if there is any painful uterine contractions at least every 3 minutes, ruptured membranes, abnormal fetal heart rate racings, uterine tachysystole, maternal systemic adverse effects, and insufficient ripening after 12 to 24 hours. We need not repeat it. So complications, I think the previous speaker dealt with, but just a glimpse of it, that is uterine hyperstimulation. So what is it? Nothing but occurrence of uterine contractions, which is lasting more than 90 seconds, or more than 5 contractions within 10 minutes, or more than 100 millimeters of mercury in amplitude, regardless of the state of the fetus. So how can we prevent it, hyperstimulation? So if the pre-induction CTG shows contraction of 2 to 3 in 10 minutes, then we can better avoid this prostaglandin induction. So how will you manage it? We have to first anticipate the complication, recognize the complication early, and if possible, we can remove the prostaglandin or stop. If oxytocin is the induction mode, then we have to stop the oxytocin. Adequate hydration should be provided to the mother, and appropriate pain relief should be there. So tocolysis, if uterine hyperstimulation persists despite measures, in the event of fetal distress, single dose of terbutaline 250 microgram either can be given IV or subcutaneous. And cord prolapse, presence of cord in the vagina when the membrane is already ruptured, where how can you prevent it is amniotomy should be avoided if the fetal head is high, and in polyhydramnios, stabilizing ARM is advocated. So what are the precautions we take is proper assessment, exclude umbilical cord presentation during preliminary vaginal examination, and the management is nothing but imminent delivery. The other complications are fetal distress, uterine rupture, placental abruption, infection, and pulmonary embolism. I think uterine rupture is more common with previous induction in previous cesarean scar and grand multi, and placental abruption is more common in induction in polyhydramnios and uterine hyperstimulation. So these are some of the checklists. Okay, so we need to fill it for proper this FOXY checklist. So before inducing, for what we are inducing, what is the gestational age? Is the gestational age correlating with her earlier ultrasound? Any high risk present, and what is a prior pre-induction Bishop score? Everything should be documented and signed. And the induction of labor, what we are going to convey to the patient, what method we are inducing, what are the do's and don'ts of it, and what are the success rate of it, everything we have to document it. And this is the consent form finally. So just I need to show you a video. Please stay online.
Nishant?
Yes, Chitra. Um, Ma'am, we have two questions from the attendees. So the first question is from Dr. Dhanapal. Previous LSCS less than 1 year method of induction in anomalous baby. Is it possible? And the second question is TBT. What about the infant mortality?
Shanmugapriya?
Ma'am, is the video visible, ma'am?
Yeah,
Yes,
yeah,
ma'am.
the video is visible. Regarding the questions, we'll go back to it later. Okay, we'll finish the video first.
Yes, ma'am. So this is a method of insertion of Foley balloon catheter. I think most of us were using it, but still just a brush up of it. So either you can guide it by digitally or by the use of Cusco speculum, where you have to, under sterile precautions, aseptic precautions, we have to expose the vagina and visualizing the cervix. We have to insert the balloon catheter guided by a ovum sponge holding forceps, which should be inserted such that the bulb goes beyond the cervical canal above the internal os and should not remain within the cervical canal or in the vagina. So only after insertion, correct position, we have to start inflating the balloon, and we can inflate to about 30 to 70 ml can be the balloon can be dilated and should remain beyond the internal os, where we can confirm it by digital examination. So this is the digital way of inserting the Foley catheter. So what we are going to do with the remaining part of the tube, we have to clamp it with the cord clamp, and then we have to tie it with the bandage to the maternal thigh. So the fetal heart rate can be monitored for the next 30 minutes, and then the mother can be made walkable, and she can do her routine day-to-day work. So this can be supplemented with oxytocin infusion also for initiation of uterine contractions. So finally, induction of labor is a fairly common procedure which is known to carry inherent maternal and fetal benefits and risks. So the systematic and comprehensive planning followed by adequate, appropriate and timely implementation of induction of labor are the keys to quality improvement in clinical management and safety practice. Thank you, ma'am. Thanks for this wonderful opportunity by the OXOC. I thank Dr. Chitra madam and Dr. Rekha Rajesh madam, and my sincere thanks to Dr. Anita madam and Dr. Surbi madam for giving us this opportunity and constantly motivating us to present this topic. Thank you, madam.
I think we should go back to the chat box questions, isn't it?
Okay.
Aren't you going to answer all those?
Okay, ma'am.
Chitrakala?
Yes, ma'am. I forwarded to Siva Priya, madam.
Okay.
Those two questions on chat box.
Shiva, you're there? I think the questions were about the previous cesarean induction. More than one.
Yeah, the first question is the previous.
Yeah.
Previous
more than one cesarean.
CS is less than 1 year method of induction in anomalous baby.
Actually, there are some criteria for induction in previous cesarean section. So even for a successful, there are some criteria for successful VBAC. So where less than 1 year is again not a favorable criteria for induction. So since it is an anomalous baby, I think mostly all anomalies will be found out at second trimester. So it can be done with caution. As I already told, there is it's not a contraindication, but still there are no much of studies regarding the success of VBAC in a cesarean section, previous cesarean section. But having considering less than 1 year, we have to be caution to avoid uterine rupture.
See, second cesarean and not one cesarean, you can try for VBAC, but
Yes,
more
ma'am.
than one cesarean, it is 100% contraindication.
Yes, ma'am.
In fact, it will be an elective LSCS at 37 weeks.
Yes, ma'am.
Anomalous fetus, we will probably, as you said, it should be diagnosed very, very early, at least with 2 cesarean sections in history. We will be very careful with the third pregnancy for ruling out anomalies early.
Yes, ma'am.
The second question is TBT. What about the infant mortality?
See, these are all studies which were underwent. So the term breach trial, as I already told, the long-term consequences are still not highlighted in term breach trial. So where based upon the morbidity of the fetus as well as the mortality in the infant, infant period, it's still not justified. So the planned cesarean section is more favorable for increasing the perinatal outcome compared to vaginal delivery, but still vaginal birth can also be allowed when we have competence in proceeding with a term breach delivery.
I think between the two of you, Shanmugapriya and Sivapriya, there was
Yes,
a little controversy. In fetal macrosomia, you said it is you can give a trial, and Shivapriya said for shoulder dystocia problems to be ruled out, you have to go for an elective LSCS
yes,
in GDM.
myself also.
So you are both contradicting yourself.
No, ma'am. Actually, as per guidelines, what I said is, as per NHM guidelines, elective cesarean section has to be planned for a fetal macrosomia suspected case. Whereas, according to Cochrane review latest, what they saying is that fetal macrosomia, considering it, there is no point in prior induction compared to expectant management, ma'am.
So that
So that's the controversial. Yes, ma'am.
It means that elective LSCS is to be.
That finally depends upon the consultant, ma'am.
Nobody will want to take a risk.
Yes, ma'am.
Okay. Anything else? Anita, are you unmuted?
Madam?
We would like Anita to be unmuted, please.
Chitralekha, madam. Yes.
Sure,
I think ma'am has to be included in the panelist thing, madam. Then only we can unmute her.
Ma'am, done, ma'am.
Madam, I like to discuss that point, madam, that oral misoprostol is also with meconium stabilizer.
Yeah, that is
because
true.
yes, madam, I found that the peak plasma concentration will be reached in half an hour in oral misoprostol, madam, and also it will be cleared very rapidly. By about 2 hours, the oral dose will be cleared. But for vaginal preparation, the peak plasma concentration will be attained only at 70 to 80 minutes, and it will last for up to 6 hours. So in case of oral misoprostol, I think more dose will be required to achieve the same effect as that of the vaginal. So maybe because of higher doses can go for meconium stabilizer frequently.
So you mean the frequency of the duration of
Yes,
the drug is more? So yeah.
Even by guidelines also, the oral misoprostol should be repeated 2 hourly, whereas for vaginal it can be repeated 6 hourly.
Madam, good evening, ma'am.
Good evening, Anita.
Yes, ma'am. The absorption rate and the therapeutic level in the blood is more, ma'am. So and it is cleared rapidly also with oral dosage. So the level, therapeutic level in the blood will be more. So the more chances of distress, ma'am.
Yes, fine. That is what I
absorption
wanted
is
to
low,
share.
like just like our glycemic index. We say low glycemic index and high glycemic index. The absorption is slow
So,
and
right.
sustained.
Mm.
Slow and sustained,
So the
whereas it is rapid and it is more, and the blood level is more. So
the
regarding the
concentration
question,
is more. Okay.
regarding the question on induction of labor in a case of previous LSCS 1 year old with anomalous baby, I want to know the gestational age, ma'am. If it is an
No, that is
anomalous
what we decided. It will be
second
definitely a
trimester,
second trimester abortion only.
second trimester abortion, then we have to be very careful in monitoring. We have to be more watchful about the rupture. We can try, of course. It is an anomalous baby. We can have repeated doses of mifepristone. Mifepristone in this case, we have used with good results. So we can give one dose of mifepristone, repeat another dose after 24 hours. Then when we repeat the mifepristone, we insert also a Foley's catheter. With this alone, they deliver, ma'am, without any
Mifepristone 24 hours interval or 48 hours interval. I think 48 hours interval
repeat
is
the dose.
better.
No, ma'am. In 24 hours, we again give another
Intervention
mifepristone.
after. No, what I'm asking is mifepristone.
No, ma'am, I'm not
day
telling
one,
about
first
misoprostol.
dose. Not meso, Mefi only.
Then again after 24
you give
hours,
a second
Mifi only.
whether with Foley's
Second
you
dose
said
also,
no.
mifepristone.
Foley's, not second
With
dose.
Foley's, we
First
can
dose
insert.
with Foley's should be after 48 hours or 24 hours.
After 24 hours, we can repeat mifepristone again. And then if needed, misoprostol. Since you said it is LCB is 1 year alone, so we try with more mifepristone rather than misoprostol, which causes intensive contraction. So mifepristone.
Yeah,
With
meso
this
we have all
alone,
decided it is not yet. It's not very safe.
Yes,
okay. So oral mifepristone alone, or along with that, after 2 doses, first 1 dose. If not, it is not achieved. Again, you can give the second dose. Again, after the second dose, you can put in a Foley's after another 24 hours. Is that correct?
No, ma'am. With the second dose, we can put Foley's, or with the first dose itself, we can insert a Foley's. Foley's can be inserted with the second dose.
Okay. Okay. Simultaneously, huh?
Simultaneously, or with the first dose also, we can insert Foley's.
Okay. Okay. Fine. Fine. Anything else? Chat box. Nothing. Now, I think I would like to thank Team Shield for a very, you've been continuously supporting us, and I hope you will continue to support our web meetings. Thank you so much, Mr. Balaji, Mr. Nishant, and Mr. Chitrakala.
Thank you very much, doctor. Thank you.
So much.
Thank you, ma'am.
And we also received feedback from one of our delegates that all the presentations were nice by all the 3 speakers.
Yeah, the speakers did a very wonderful job. It shows how much of hard work they have put into this, preparing this topic. And it is very useful and the need of the hour. Most of the practicing obstetricians, I have seen so many people have logged in already. That is very good. Very good attendance. Thank you so much.
Thank you, madam. Thanks a lot.
We will wind up the meeting. Thank you.
Thank you. Thank you. Thank you, ma'am. Thank you.